Welcome to the Deep Dive. Today, we're cutting straight through the noise on a really common issue, urinary tract infections, or UTIs.
That's right.
We're going to dive into how diagnosis is changing, what improvement actually looks like, and importantly, modern ways to prevent them, especially those frustrating recurrent infections.
Yeah, it's a critical topic. There's just so much information out there, and honestly, a lot of it's pretty outdated. We've looked at the latest clinical guidelines, systematic reviews, really trying to get a clear picture for you.
And the numbers are huge, aren't they? Something like 50 to 60% of women get a UTI at some point.
Exactly. But what we're really focusing on today is recurrence. You know, for 20 to 40% of those women, it's not just a one-off thing.
And that's what you call RUTI, recurrent UTI.
Precisely. Clinically, we define that as 3 or more UTIs in a year, or maybe 2 or more within just 6 months. The impact on quality of life is just massive. Stress, healthcare costs, it adds up.
Okay, so let's start with basics. People know the usual signs: needing to pee constantly, the urine looking cloudy. But what's the main physical feeling that signals an acute infection?
Well, the central symptom, the one we really look for in diagnosing acute cystitis, is dysuria.
Dysuria, meaning painful urination.
Yes, exactly. Painful or just really uncomfortable. And understanding why helps. It happens because urine, as it passes out, physically touches the inflamed lining of the urethra.
Oh, okay.
And then the bladder muscle, the detrusor, contracts, which just makes that irritation worse. It's a direct physical thing.
So it's literally inflamed tissue getting irritated.
Got it.
Now, when someone starts antibiotics, there's always that anxious wait. Is it working? The research points to, 4 key signs that things are improving?
Yeah, and you usually see these positive signs within about 48 hours, a couple of days. The first 3 are pretty intuitive, localized things.
Okay.
1, noticeable improvement in that lower belly or pelvic pain or discomfort. 2, things feeling more normal when you urinate, less burning, less stinging. And 3, the urine starts looking clearer again, not so cloudy.
Okay, those make sense. But the 4th one is improved energy. That feels a bit more general. Is fatigue really that common with a UTI?
Oh, absolutely. It's something people often underestimate. Even a supposedly localized infection can make you feel generally unwell systemically. That fatigue, low motivation, it's incredibly common with more significant infections. So yeah, getting your energy back, feeling more alert, that's actually a really good sign the body's winning the fight.
Good to know. But sometimes it goes the other way. What are the red flags? The signs that maybe it's not just a simple bladder infection anymore, that it might be spreading, say, to the kidneys.
These are critical. If you see these, you need to seek care right away. First, a high fever, usually over 101 Fahrenheit, maybe with chills, shaking, or even drenching night sweats.
Okay, that sounds serious.
It is. Second, any new or worsening pain specifically in your side, lower back, or even the groin. That pattern often points towards kidney involvement. And third, things like nausea, vomiting, or especially in older adults, sometimes it's vaguer, like sudden confusion or changes in awareness. Those need immediate attention.
Okay, let's shift gears a bit, because this next part seems to really challenge what many of us learned, this idea of the human as habitat model.
Right.
We were basically taught the urinary tract is sterile, right? But now science suggests it has its own microbial community.
Yeah, this has been a major shift. It fundamentally challenges decades of UTI dogma. Using more sensitive techniques, molecular methods, advanced cultures, it's become clear the lower urinary tract isn't sterile at all.
Wow.
It's actually a complex ecosystem when healthy.
Yeah.
And acknowledging that completely changes how we need to think about diagnosing infection.
So if urine isn't sterile, what does that mean for the classic gold standard test, the standard urine culture? What are we even measuring?
That's the million-dollar question, isn't it? The big problem is the threshold we've traditionally used to call a culture positive. That number, 10 to the 5th colony-forming units per milliliter. It was set over 60 years ago. And get this, it was based on studies of women who were completely asymptomatic.
Wait, hang on. The threshold we used to diagnose a painful symptomatic infection was based on people with no symptoms.
You got it. It sounds absurd, but that's the history. And because of that, if you apply that rigid threshold to women who actually do have symptoms, its diagnostic sensitivity is terrible. It probably misses 40, maybe even 50% of actual infections.
Staggering.
It is. And then there's the whole issue of contamination. Getting a clean midstream sample is tricky. Skin bacteria often get in, leading to mixed results that just confuse things. If you see a mixed culture or really low counts, you have to suspect contamination. Sometimes a catheter sample is needed just to get clarity.
This leads us straight into asymptomatic bacteriuria, or ASB. So bacteria are there, but no acute symptoms like that dysuria we talked about.
Exactly.
This feels really counterintuitive, especially for someone getting recurrent UTIs.
Yeah.
If you find bacteria, shouldn't you just treat it, get rid of it? Why leave it alone?
This is probably the single most important and maybe hardest concept to grasp in modern UTI management. The strong consensus now is do not screen for or treat ASB in patients with recurrent UTIs.
But why not? Isn't it risky?
It seems risky, but the evidence shows treating ASB doesn't actually improve outcomes. In fact, it causes clear harm.
Harm. How does treating bacteria cause harm?
Well, think of it like this. Those bacteria might be harmless, maybe even protective, occupying that niche, if you wipe them out with antibiotics.
Clear the way for something worse?
Precisely. You might allow more aggressive, potentially drug-resistant bacteria to take hold. Treating ASB is associated with an increased risk of getting a symptomatic UTI later on, and it definitely drives antibiotic resistance. The focus has to be on managing symptoms, not just the presence of bacteria.
Okay, wow. So if the old culture test is flawed, what about the new high-tech options? PCR, next-generation sequencing, NGS. They can find tiny amounts of bacteria. Are they the answer, or do they just create more confusion?
That's the dilemma we're facing now. These molecular tests are incredibly sensitive, yes. They give a much more detailed picture of the urinary microbiome.
Right.
But they're so sensitive that almost everyone, even perfectly healthy asymptomatic people, will show some bacteria. So if we rely only on these tests without strong clinical judgment, meaning asking, does this person actually feel sick? Do they have symptoms? We risk massive antibiotic overtreatment.
Right. More data isn't always better data if you don't know how to use it.
Exactly. The future isn't just better tests, it's better judgment. Knowing when not to treat is just as important.
Which is the perfect lead-in to modern management and antibiotic stewardship. We're dealing with rising resistance, the collateral damage of repeated antibiotic use.
Absolutely. The whole approach is shifting. When treatment is needed for an acute episode, the key is precision. Short durations, generally no more than 7 days. This balance is clearing the infection with minimizing resistance risk and side effects.
And using the right drug.
Yes, using first-line options like nitrofurantoin, TMP, SMX, or fosfomycin. But, and this is crucial, the choice has to be guided by the local antibiogram.
The what now?
The antibiogram. It's basically a local report card showing which antibiotics still work against common bacteria in your specific geographic area. Resistance patterns vary hugely from place to place.
Okay. Local intel is key. I also found this idea of expectant management really interesting, just using pain relief and hydration while waiting for culture results for uncomplicated cases.
Yes, it's a valid option and probably underutilized. For a straightforward, uncomplicated bladder infection, the risk of it progressing up to the kidneys is actually quite low.
So the risk-benefit might favor holding off on antibiotics sometimes.
For many patients, yes. The potential harms of unnecessary antibiotic side effects, resistance, disrupting the microbiome can outweigh that small risk of progression. We need to be more comfortable with watchful waiting in the right situations.
And what about self-start treatment for people with recurrent issues?
That's another strategy. For selected, well-informed patients who know their symptoms well, clinicians might provide a prescription to fill and start immediately when classic symptoms begin. Though ideally, getting a urine culture before starting the antibiotic is still best practice if feasible.
Okay, let's talk prevention. This is where people often feel they can take some control. What actually works based on evidence beyond antibiotics?
Top of the list, surprisingly perhaps, is hydration. Simple, but effective. There's a conditional recommendation for women with RUTIs who typically drink less than 1.5 liters a day.
Just drinking more water.
Pretty much. One key study showed that women who increased their daily water intake by 1.5 liters cut their number of recurrent UTIs almost in half, from about 3.2 episodes a year down to 1.7.
Wow, that's significant.
It really is. The goal should be aiming for a daily urine output of at least 2 liters, 2,000 milliliters. It literally helps flush things out.
Makes sense. What about the old standby? Cranberry, does it actually do anything?
Cranberry can be offered. There is science behind it. The active compounds, proanthocyanidins, or PAICs, seem to work by making it harder for bacteria to stick to the urinary tract walls.
Okay.
And it's a big, But the effectiveness seen in studies relies on getting a specific standardized dose, usually at least 36 milligrams of bioavailable PEGs.
Bioavailable PEGs. That sounds specific. Can you get that from juice or typical supplements?
That's the problem. Most juices have way too much sugar and not nearly enough PEGs. And many supplements aren't standardized, or the PEGs aren't in a form the body can actually use effectively. So finding a product that truly delivers that clinical dose can be tricky. It's not as simple as just grabbing any cranberry pill.
Right, the devil's in the details. Now, for perimenopausal and postmenopausal women, hormones play a role, don't they?
Yes, a significant one. For this group, vaginal estrogen therapy is strongly recommended. As estrogen levels decline, the vaginal microbiome changes, losing some of its protective bacteria, which makes UTIs more likely.
And topical is better.
Topical, like a vaginal cream, is generally preferred over systemic estrogen. It works directly where it's needed with minimal absorption into the rest of the body, reducing potential risks.
Are there other non-antibiotic options, like D-mannose? I hear about that a lot.
Methenamine hippurate is another non-antibiotic option that may be offered conditionally. As for D-mannose, while popular, the current evidence suggests that using D-mannose alone for prevention might not be effective. It needs more robust study.
Okay, good to clarify. Finally, let's bust some long-standing myths. Wiping front to back, peeing after sex, avoiding hot tubs. Does any of that hygiene advice actually prevent recurrent UTIs?
This might be surprising, but the evidence says no. All those things, wiping direction, avoiding habits around sex, avoiding hot tubs, douching, none of them have been proven to actually reduce the risk of our UTIs.
Seriously, all that effort.
Seems so. It might feel like a relief for some. The one lifestyle factor that is confirmed to make a difference is avoiding spermicidal products. Spermicides can disrupt the healthy vaginal flora, increasing UTI risk.
Fascinating. So much common wisdom just isn't backed by evidence. This whole conversation really shifts the perspective, doesn't it? Away from just killing bacteria all the time.
It really does. The big picture is moving from simple eradication, which we now know is often impossible and maybe even counterproductive, towards stewardship, symptom management, and recognizing the urinary tract as a complex microbiome.
For me, the two biggest takeaways are, one, how that standard urine culture threshold is basically built on flawed foundations.
Right, derived from asymptomatic people.
And two, the simple power of hydration. Just drinking more water being a clinically proven prevention strategy. That's huge.
It highlights that sometimes the best interventions aren't high-tech drugs, but understanding and supporting the body's own defenses.
So a final thought for our listeners to chew on.
Well, think about this. We have these amazing new technologies like NGS and PCR that can detect bacteria with incredible sensitivity. But maybe the real leap forward in managing UTIs won't come from just better testing. Maybe it comes from better clinical judgment. Meaning knowing when to treat versus using supportive care, leveraging these non-antibiotic strategies more effectively, and looking towards the future, things like modulating the host immune response, or maybe even vaccines like MV140, which is already being used in some countries to actually prevent recurrence. Better thinking, not just better tech.